So this presentation is on diagnostic imaging. So there was a systematic review done in 2022 of studies in Canada. There were 34 studies included, and they measured the overuse and underuse of diagnostic imaging. And there was a median of 13.8%. 13.8% of the diagnostic imaging was either overused or underused, and that ranged from 4.5 to 29%. So pretty large underuse and overuse. And these were the 34 studies between 2007 and 2021. So this over and under use of diagnostic imaging can lead to a lot of harms, such as I have struggled with this word, iatrogenic harms to the patient. So this could be, for example, having an allergic reaction to the contrast that you received during your imaging. Longer wait times, we're all very familiar with those. Poorer health outcomes due to delays in diagnosis, and this is closely linked with the longer wait times. And also, inefficient use of our scarce healthcare resources, and that's not only access to the imaging machine, the diagnostic imaging machines, but also the medical technicians who perform these imaging, our radiologists, our referring physicians, and patients' time as well. To make matters worse, it has been estimated that in the next, 17 or so years between 2017 and 2040, the number of CT and MRI exams are expected to more than double. So that just further exacerbates these harms. So this is where guidelines can come in to potentially help with these situations. But we want them to be trustworthy, and recommendations within these guidelines should be evidence-based and be developed using rigorous methodology. The recommendations should also be contextualized, considering the equity, the accessibility, the resources, and that's, in our situation, that's specific to the Canadian healthcare systems. And I use plural systems because we really do have different healthcare systems across all provinces and territories. And this was really the catalyst to this work that we've been doing. One of the working group co-chairs approached our organization. They have a clinical decision support system running at their hospital in Toronto, and they're using recommendations that have been developed by the UK, and they've been having to make a lot of edits to the recommendations because they're not contextualized to the Canadian healthcare system. So this is what started the conversation for this work. So in 2020, the CAR, funded by the Canadian Medical Association, began working on diagnostic imaging referral guidelines. We have an oversight committee, which we call a working group. This is made up of 16 members, and they represent radiologists as well as allied health professionals from across a variety of national medical bodies and specialty societies, including the ones you see here: the Canadian Association of Emergency Physicians, the College of Family Physicians of Canada, Choosing Wisely, Nurse Practitioners Association of Canada, and the Society of Rural Physicians of Canada. We also have a patient and family advisor on this working group. So they make kind of the project-wide decisions for each of the guidelines that we're making for these. The overall mandate of this work is to develop a comprehensive set of evidence-based diagnostic imaging referral guidelines that are ultimately suited for integration into clinical decision support systems. That kind of encompasses the subpoints here, but we do want to produce a comprehensive set. So we know with CDS, we really need, a lot of scenarios to be covered. So really to try to cover, most of the big hitters that people are going to search recommendations for. as closely as possible based on our methodology. We have to do some adaptation, but we are following the GRADE methodology. This is largely considered the gold standard in Canada for developing guidelines. And this really helps us create context-specific recommendations. We are producing these guidelines as a public good. We're going to make them available on our website, and also are going to be publishing these in an open access journal. And we are working with several people, several organizations to integrate these into CDS software systems. And we're also, once we kind of get further along in the process, we're going to develop a toolkit for the rollout of a CDS system, and this should help, other organizations do the same, lessons learned, what worked, what didn't, those types of things. So why clinical decision support? Physicians across all disciplines are facing increased pressure due to several factors, such as, volume of patients and ongoing systemic and practice changes. It does have the potential to benefit all aspects of healthcare, with patients really being the primary benefactors by ensuring that they get the right test at the right time. And CDS, if you're not familiar with these, they are systems that have embedded guidelines. They often work with electronic medical records. And these guidelines, as I said before, if they're comprehensive, they'll provide recommendations for numerous clinical scenarios, and it really helps guide the referring clinician to determine what the best test or referral to recommend, and in several cases, maybe ones to make sure to not recommend, and that's where the overuse factor comes in. Additionally, provinces are beginning to demand CDS to be part of their workflow. So the last CAR guidelines were published in 2012, so they're over a decade old now. You can see that there were 12 sections within the guidelines, and I won't bother reading them out here, but you can see them in the left column. And on the right column, you can see the number of clinical scenarios that were addressed within each of those sections. Some are larger than others, for example, pediatrics and cancer, which encompass, kind of a wider spectrum of scenarios potentially. And then we have, more specific sections, spine, musculoskeletal, for example. And back then, there were 338 clinical scenarios that were covered, so a fairly large amount of scenarios. So why are we revising / redoing these guidelines? Well, as I mentioned, they're over 10 years old now, so it's common practice to update guidelines to reflect the current evidence. So, new studies that have been done, as well, particularly in this area, technological advances. Imaging machines are being upgraded, updated, offering less radiation exposure, offering better imaging quality images, etc. So we really want to capture the newest information. Over these past 10 years too, there has been a lot of development in how to create good guidelines, and this is large for us. The one we're using is largely informed by the GRADE group, and if you're familiar with that group, they have well over 40 publications in the past 10 or so years, which provide guidance on how to develop good guidelines. As well, and we felt this was particularly important, in 2012, there weren't referring clinicians involved in the recommendations. And as they are really the primary users of those recommendations, we really felt that they needed to be involved in the process of developing the recommendations. So for each of those 13 sections that you saw on the previous slide, we make up a group of individuals, which we call expert panels. These panels are made up of 6 to 9 members. Within each panel, we have representation from radiologists, referring clinicians, and this could be family physicians, specialty physicians, for example, obstetricians. We have a patient and family advisor and a guideline methodologist, who is me. And as these guidelines are being formulated for Canada, we do aim for national representation. So we want to have these members represent BC, Western Canada, Ontario, Quebec, and Atlantic Canada. On a few occasions, it is hard to get this representation, not only of the member, of how they're made up, but also the national representation. But we try to mitigate any risk in not having this by having our working group review the guidelines as well, and that we have national representation across there. We also get external peer reviewers as well. So if we're unable to meet these criteria, then we make sure that we have this during our review process. So to develop the guidelines, this is kind of our general project process overview. So we are staggering the 13 sections. We have a relatively small team working on these guidelines. It's primarily myself, and then I have a second reviewer help me during the scoping review period. So and following, best practice, we do get the expert panel members to complete and sign conflicts of interest and terms of reference. We meet, everybody introduces themselves, we discuss the overall mandate and process, and the next step, which is revising the scenarios. So we do use the list of scenarios from 2012 as kind of our starting points for discussion. And we, restructure or rename these scenarios so that because we want to integrate these into clinical decision support systems, we really try to get this as kind of the clinical presentation of a patient. And this is, discussed over a meeting and finalized. And this list of scenarios, first, it informs our systematic search strategy. So we get a library scientist to conduct a systematic search strategy for our rapid scoping review. But then this list of scenarios also, is how we present recommendations for each one of these. They might change slightly during the recommendations formulation process, but for the most part, they are kept in that list. So the rapid scoping review, I'm going to expand on this on our methods on how we do this, the rapid part of it further, but we do map the recommendations and distribute this information to the expert panel members, and they review these most of the time it's, a document of 70 to 90 pages, so not overly digestible. So I do read through all of the recommendations across the included guidelines for each scenario and make a synopsis and really highlight the concordance and discordance among the different guidelines. And that really helps the discussions when we meet to formulate the recommendations. We do have a guideline template, and I fill in, the expert panel specific information, the search Prisma flow diagram, all the things that you would expect to see in the methods and results sections of a review. And this is reviewed and approved by the expert panel members. And as I said before, this is distributed to the working group as well as external stakeholders for additional peer review. So during our systematic scoping review, we really do try to use kind of best practice guidance methods within our conduct. So we have, following the Prisma P checklist, we have written a protocol. It will be published in the CMAJ Open. I submitted the final approval of the proofs today, so hopefully that will come out soon. If you want a copy, please email me. I'll be happy to share it with you once it becomes available. To conduct the scoping review, we use the Joanna Briggs Institute guidance. And if you're unfamiliar with the scoping review, it allows for mapping of the body of literature and can be conducted to summarize and disseminate research findings. We also use rapid review kind of accelerations to get the scoping reviews done in a faster timeline, while recognizing that there are some limitations to some of the shortcuts that we've taken. But we have used the Cochrane Rapid Review Methods guidance to help guide us in this process. And to develop the guideline, we are using the Jen McMaster Guideline Development Checklist and grade for guidelines guidance, as I said before, adapted where necessary. So our inclusion criteria, and this is why we've had to adapt the grade, is we're not conducting a systematic review of primary studies. So we don't go through the grade for the systematic review level. So the risk of bias, the indirectness, imprecision, all those domains. But because of that, we really do want to capture systematically produce guidelines. That's our unit of inclusion. There's a lot of really good guidelines that have been conducted and published or available through websites. So we don't need to reinvent this by looking at the same primary studies that they've looked at. So we are harnessing the work that other organizations have done here. But as I mentioned, we do want them to be systematically produced. So using the Agree To checklist, which is a guideline checklist for conduct and reporting, we went specifically to the methodology section, and we highlighted 3 of the questions as really what is going to help us determine whether it was a systematically produced guideline or not. So we want to make sure that systematic methods were used to search for the evidence. So we want them to say, they searched and named at least one electronic database using an electronic search strategy. We also want the criteria for selecting the evidence or their studies that they included. We want this to be clearly described. So, they have to offer some methods around how the formal process for study selection. And we want them to provide an inclusion and exclusion criteria. Sometimes, though, if they might not report this explicitly in the guideline, but if they say that they've done a systematic review, not a literature review, but a systematic review, we consider this sufficient. And the last criteria is that we want the strengths and limitations of the body of evidence to be described. Because we're not doing this, we want the guidelines to provide us this information. So they need to perform some type of critical appraisal on the included studies. So for example, a risk of bias, or describe the study limitations. We don't want them judging the quality of a study based on the study design. For example, it's an RCT, it's the highest level. We don't consider that a critical appraisal because RCTs are not always well reported or conducted, and also because in this area, particularly around diagnostic imaging, we do expect to see observational studies as the primary studies of inclusion. Again, if it was based on a systematic review and they performed grade or some type of evidence evidence-informed practice to do critical appraisal, that is sufficient as well. To capture the most recent studies and for feasibility, we are looking at guidelines that have been published 5 years prior to when we run the search. And we are looking for English published guidelines as well, again, for feasibility. We don't limit the search strategy on language. So if we do capture potentially relevant guidelines published in other languages, we do have an appendix in our guidelines that show a list of these guidelines. So if people are interested in reading those other languages, then we provide that list to them. So during our title and abstract screening, we really do harness, we use a software tool that has artificial intelligence and more specifically active machine learning embedded in the well, throughout, but we use it in the title and abstract screening phase. We do have, and it's not uncommon to have large search yields when you do a systematic scoping review, particularly in this. We're getting fairly large ones because we're including so many clinical scenarios. You know, it's not unheard of to see 6,000 to 9,000 citations. So in order to get through these faster, many of which are not relevant, but to help us get through these, we are using active machine learning to help us. So there's a diagram on the right-hand side of the screen, and it kind of shows the process of how the software learns. And so it's an iterative process. So basically, and this is very software specific. I can't speak to other softwares necessarily, but it would be something similar to this. The human reviewer screens a set of records. In this instance, it's to a minimum of 25 records to a maximum of 200 records per iteration. And they're shuffled and the reviewer screens them. And then the AI learns based on the inclusion and exclusion decisions that the human screener has made during this time. And then it assigns a score based on the likelihood of inclusion to the rest of the records that haven't been screened yet. And then it resorts the records and it presents them in this order, so prioritized screening order for the human reviewer to continue screening. And this is all done in the background. Unless the reviewer knew this was specifically happening, they wouldn't be. It's very seamless in the background. And then the human reviewer screens another 2%, and then it learns, the active machine learning learns through all of the records, so those two iterations, and again assigns a new score to the remaining records and sorts the records and displays them in order of likelihood of inclusion. And this process continues until you decide to stop screening, which could be, you know, at the end of it all, or in our case, we have set up a stop screening rule, and I'll explain this later. So this process allows for, as I said in the third point here, allows for modifications from the traditional screening methods, which, you know, a lot of people use that dual independent review. So these are some diagrams from the software that I use. And it really offers a huge reduction in the screening burden. So we have set a stop screening rule once 95% of the predicted relevant references have been identified. There's some empirical publications, empirical evidence, sorry, that shows that you know, having identified 95% of the predicted relevant records usually happens within about 40% of the total records. And this may range depending on the data set you're working with. But you can see this leftmost diagram. It shows me throughout the screening process, you know, what percentage of records it has of the relevant records it predicts I've found. And in the middle diagram, you can really see the line chart to show, you know, we found a lot, you know, in the first, say, 750 records that were screened, we found most of the included records. So we found 150 of the included records. And as we screened another 1,500 or so records, we found 14 more. So you can really see the line, kind of flat line at the top there. And just to say, we have run some experiments, some simulations on this too, and we found, as well as some other software designers have found, that even though it's predicting 95%, it's actually closer to 98 to 100% of the records that you would have included had you screened everything. So it's fairly accurate. And the third diagram on the right-hand side of the screen, it shows you the remaining records that have not yet been screened and what percentage of likelihood of inclusion that they would be, where they fall. And you can see here, all 3,592 remaining unscreened records have a likelihood of inclusion of 0 to 9%. And there's actually another part of this screen that shows you what the highest record is. So it could be 7% or whatever. As not every, I trust the AI, but not everybody is at that stage yet. So we do additional checks along the way. This software also has an audit check where it identifies excluded records with an inclusion score of 0.85 or greater. So we rescreen those just to ensure that we haven't incorrectly excluded a record. And once all the records are screened, we do get the AI to screen the rest of the records out for us, but we don't want to leave it at that. So we do get a second human screener to verify 30% of the records, 10% of the included and 20% of the excluded. This screener has no knowledge of whether the record was included or excluded by the first reviewer. So it is blind in that sense. And this allows for, we do consensus and discussion here as well, just to, if there's any conflicts. Usually there's usually a pretty low number of conflicts, fewer than 10 over, 1,200 to 1,700 records. So a really low rate of conflicts here. So. And then just quickly to wrap up our methods here, we do supplemental searching just to make sure that we haven't missed anything. So we look at the ACR appropriateness criteria website. We do have the Royal College of Radiologists iRefer guideline book. And then we look at specialty specific guideline groups, depending on the section that we're working with. For example, for the obstetrics and gynecology, we looked at the Society of Obstetrics and Gynecology of Canada. And the expert panel members can also bring forward guidelines that we will evaluate against our eligibility criteria to see if they should be included if we haven't captured them. For full text screening, we do a pilot exercise by 2 reviewers, 25 to 30 records, for example. If there's good agreement, then we'll stop there. If there's not, then we'll pilot some more. We resolve the conflicts, and then a single reviewer screens the remaining records. For data mapping, a single reviewer extracts, and then we verify the extracted information by a second reviewer. And then we do critically appraise the included guidelines using the agree to checklist. Again, we do single reviewer, and then we verify the extractions or the judgments here as well. Just check the time. Okay. So after the group looks at the mapping of the other recommendations, as I mentioned before, we use the grade system or the grade process, which is grading of recommendations, assessment, development, and evaluation. So you can see the diagram on the right-hand side of the screen. We basically have 4 recommendation options. We can have the strength of the recommendation, which is either strong or conditional, and the direction of the recommendation is either for imaging or against a particular imaging. And using the guidance from GRADE, we have developed, for example, if we look at a strong recommendation for, we use the words we recommend. If it's conditional, we would use the words we suggest. And within the GRADE guidance, we have some text here too. For example, strong for, we would say almost or almost all informed people would recommend or choose the course of action, and only a small proportion would not. A patient should request discussion if the intervention is not offered, for example. So you can read the others. So within the GRADE for guidelines, it really talks about it really works with the contextualizing the recommendations, and this is done by looking at the benefits and harms, the values and preferences, equity, accessibility, acceptability, and resources and costs as well. So just I mean, this is across all recommendations really. In particular for the diagnostic imaging ones, they are really just to assist the choice of imaging modality in situations where it is felt clinically necessary to obtain imaging. We don't always provide indications where it might be clinically necessary. In some instances, we do have some decision rules or tools that guide that. But every patient is different. The scenarios may be different, so there really is some clinical expertise that comes into this as well, obviously. They're not intended to stand alone. Medical care should be based on evidence, a clinician's expert judgment, patient's circumstances, values and preferences, and resource availability. And we do, in Canada, particularly, not all imaging modalities are available in all treating locations, particularly in rural or remote areas. So decisions about whether to transport a patient for recommended imaging or perform alternate imaging is difficult and should consider the expected benefits of recommended imaging, risks of transport, and the patient preference, as well as other factors. So where are we to date? We have 13 groups. We have 3 guidelines that have been approved: trauma, obstetrics, gynecology, and breast disease. We have 3 other that are under review: musculoskeletal system, gastrointestinal system, head and neck. We have 3 other groups underway at various stages of the guideline development. So we have thoracic, cardiovascular, and urology, adrenal, and genitourinary systems. And we have 4 other groups that we have yet to start. So spine, central nervous system, pediatrics, and cancer as well. If you remember, the cancer group was quite large in terms of the number of scenarios. So we have developed a strategy on how to make this section more feasible. So some of the next steps as we continue completing the guidelines, we are planning and working with a professional medical translation service to translate the recommendations into French. Once the guidelines have been approved, they will be posted on the CAR website. We are integrating into clinical decision support. We're working with health authorities and stakeholders across Canada. So far, we have developed collaborations with the Government of Quebec, the eHealth Centre of Excellence in Ontario, and the Alberta Health Authority. We are planning on publishing each of these guidelines and in open access so that they are freely available in the CARJ. We really, although they're going to be posted on the website, websites don't show up in search strategies. So we really do want these to be indexed in electronic databases. We also plan on developing patient-friendly summaries. This is something that's often done. The ACR does this, Cochrane does this. So we want to make sure that we have, patient-friendly summaries, particularly for the more complex scenarios that we're covering. So just to talk about the CDS flow diagrams. So for each of the clinical scenarios, we have, the worded scenario, but we are creating flow diagrams to help with integration into CDS. We don't want the programmers to have to interpret the recommendations to put them into the software. And so I create these flow diagrams, and then I do get the expert panel members to review them once they're designed. I'm not a radiologist or a physician, so I really want to make sure that I've interpreted the recommendations properly so that they can be integrated into CDS. We are software agnostic. We aren't recommending any particular software. This is largely decided on the institutions, and although we are working with a couple of the software companies, these diagrams, we're really developing them to be software agnostic, so that regardless of what CDS somebody's using, they could use these guidelines. So here's an example of one of the guidelines from the breast disease group. So you can see on the left-hand side of the screen, the recommendations are written in, sentences, and you can see we always start with the patient population of who the recommendation is for first. So for recommendation 1, in patients with risk reduction, mastectomy, and reconstruction, we suggest, that's a conditional recommendation because we're using the word suggest, no imaging for breast cancer screening on the reconstructed sites. And then the second recommendation for this patient population, so in patients with risk reduction, mastectomy, and reconstruction presenting with a palpable area of concern, we recommend mammography or digital breast tomosynthesis, as well as targeted ultrasound as the initial imaging techniques. We do have a little bit of a caveat here. Imaging with mammography and ultrasound may differ based on facility practice when evaluating patients with autologous tissue versus implant-based reconstruction. For example, patients with implant-based reconstruction may initially undergo ultrasound, with mammography being performed only if feasible. Then patients with risk reduction mastectomy without reconstruction, we suggest no imaging for breast cancer screening. And in patients with risk reduction mastectomy without reconstruction presenting with a palpable area of concern, we recommend targeted ultrasound as the initial imaging technique. And you can see that these worded recommendations have been converted into a flow diagram with decision points and recommendations thereafter. So we've done this for a couple of the completed guidelines so far. Pretty much good timing. So I'll leave it open to questions now, if you'd like.
Oh, great. I'm a practicing radiologist, and I've done quite a bit of work on imaging appropriateness. And my question, well, first of all, I'd just like to respond to Dr. Perry's question. Hi, Tom. It's nice to see you again. I've worked extensively with Dr. Perry in the past. Tom, we have a lot of guidelines which are now coming out, and I believe really coming out in the last 5 or 10 years about follow-up recommendations. And these are based on extensive studies where people have, looked at like ovarian cysts. And then now we have very clear guidelines now about like what to follow up and when. And I think both I and many of my colleagues are putting into our reports, like as per the ACR appropriateness criteria, or sorry, not the appropriateness, but like as per the ACR guidelines, or as per the European Gastroenterology Society guidelines, or as per the Fleishman Society criteria, do a follow-up in this time period. I think, well, it'd be great to have, Canadian guidelines on that. Preparing those guidelines is a massive undertaking and requires like quite a bit of work. So I encourage all of my radiology colleagues to put the reference when we're recommending a follow-up as to why, so that our clinical colleagues, don't think that it's some kind of self-referral or self-serving situation, and to show that we are practicing evidence-based medicine. But Candice, sorry, my question for you is, I've used the ACR appropriateness guidelines extensively in the past, and they are excellent. They're so well documented and referenced, and their process is correct. And it looks like you guys are doing the exact same thing. My question is just, I'm wondering why the CAR is essentially doing the same work that has been done by other organizations elsewhere. And I can understand that there are Canadian contexts. For example, we don't have very good access to MRI in many provinces. But I don't think that necessarily changes the evidence, right? If the best test for a 23-year-old with 8 weeks of low back pain and radicular symptoms is an MRI of the spine, how is the evidence difference in Canada versus the US? I was just wondering if you could speak to why we're doing this in Canada per se, rather than looking to other guidelines from elsewhere.
Yeah, that's the point exactly, is, the ACR is very MRI heavy. Which is not always available, applicable in Canada. So sometimes just because it's the best test doesn't mean it's the test that's available. So that's really why we're doing kind of a more rapid process, is because we don't want to reinvent that wheel. Like I said, there's a lot of really good systematically produced guidelines. So we do want to harness all the information that these groups have done. And, it's interesting during our discussions with the expert panel members, even between the provinces, they're like, oh, that's your practice. We don't do that here, So it is really hard to make kind of general sweeping statements within Canada, let alone looking at what other countries do. So that it's really just to get the Canadian contextualization piece, and that's why we felt like it was safe to do a rapid scoping review rather than go back into the primary evidence.
Awesome, thank you.
Yeah.
Great, thank you. So we do have a question from Frederic, who's asked, which machine learning did you use for the screening process of the rapid scoping review?
So the systematic review software that we use is called Distiller SR. And they are actually a group in Ottawa, Canada, who have developed that software. It's pretty advanced, but there are several other options, some free, some that cost. If you're interested in learning more, I'm happy to provide a list of different software applications that are available.
Great, thank you. And we have another question from John, who asks, are medical legal concerns more likely to influence our American colleagues' guidelines?
I don't know how to answer that. I mean, I have my thoughts, but it's definitely just based on my opinion. So I will leave that open for the rest of the group to answer that type of question. I know we do put those caveats in our guidelines to make sure that say, these are just recommendations. These are not the rules. So yeah, I'll leave it at that.
All right, thank you, Candice. So I have a question. So have you used other rapid methods to inform stakeholders faster? Like, what other methods have you used, if any?
I mean, I guess within this one, we use, single reviewer screening at points, and of course AI, and that type of stuff, restrictions on the date, we've used several rapid review type abbreviations, and we just do recognize that there are there's limitations to those restrictions. But as I said, we felt pretty confident that through the methods that we've used, we will capture the really well conducted guidelines in existence, and that allows us to see the concordance and discordance among those, and then contextualize to say, well, why does the European society say this, but everybody else says this, and it's like, okay, well, maybe that's the contextualization piece. So yeah, I mean, I've used lots of limitations in many of the reviews that I've done, but it's just really important to recognize the limitations of those and try to mitigate any risks as well along the way.
Great, thank you. And we all know that there's like chat GPT out there now, and like other kind of easy to access AI tools. What's your experience in using these AI tools, and do you trust them?
So I mean, I trust, having done some experiments with the software that I use in particular. I can't speak to all of them, but I did a study, and it performed extremely well. It didn't miss any ultimately included studies in the systematic reviews. I haven't used ChatGPT that much. I did attend a presentation a couple of weeks, a group who was kind of, and they weren't for or against ChatGPT. They were just kind of like saying, how are people using this? What happens if I ask this question? That type of stuff. And and the presentation was interesting, but the chat comments were actually really interesting, because from what I saw based on that presentation, it shows that it can be helpful in situations where you have the expertise to know what the limitations are, but it could be very dangerous in the hands of those who do not, right? They've set up, for example, they got it to create a search strategy, and it was giving mesh headings and stuff that weren't true mesh headings, but it was being identified as such. It was also providing references that didn't actually exist in real life. So it's interesting. I think it might offer some uses, but it's still in its infancy. So we'll see where it goes, but very interesting anyways.
Great. So I think you all saw, but if you can answer the poll questions, that'd be wonderful. This is our last poll for the day. And then we have 2 questions. We have only a few more minutes, but I think we'll have time to answer them. From Dawn asks, how will changing technology, for example, MRI for weight-bearing imaging, be considered?
Sorry, can you repeat that?
Yes, so how will changing technology, for example, MRI for weight-bearing imaging, be considered? So how will changing the technology be considered?
So that is, could be considered one of the limitations of our process. So unless it's available in published guidelines, we might not have recommendations to inform recommendations for a particular imaging modality. And that's why, we're not going to just do this and leave it for another 10 years. We do have intention to keep these, using kind of a living systematic review method. We do hope to keep these up to date, because there are new imaging techniques and modalities and protocols and all that kind of stuff coming out. So yeah.
Great. And then final question from David. Along the same line, what Tim was mentioning, is there any value in individual provinces developing their own guidelines?
So that's the nice thing with the CDS, because we can put these recommendations into the CDS, and a lot of them do allow for modifications within the system. So you might have the main recommendation as developed from our guidelines, but it allows edits for, people can go in at their institution and say, here, this is the protocol that we use for this MRI. For example, or, we have found, for patients like this, send them for this, whatever, you can make it more specific to that institution. So that's the nice part of the CDS, as well, as that you can make those edits to the recommendations. You have the original, but you're also, you can add some additional context to that, which might be provincially dictated or institutional preference as well.
Great. Well, thank you so much. That was such an informative presentation.